Without further ado, I'd like to welcome our listeners to the 7th POCUS Journal podcast. We have an incredible lineup tonight. We're really fortunate to have all of the authors of the one of the best curriculum that we've had published in POCUS Journal. This is from the April 2023 issue, volume 8. It's on page 9 for those of you looking on. The article we're going to be referencing is called Teaching Old Dogs New Tricks, POCUS Education for Senior Faculty. And we have Dan Restrepo, Tommy Heyne, Christy Schutzer, and Renee Dversdal here today. I'll let them go around and introduce themselves. We'll start with Dan. Tell us about yourself, your POCUS, first kiss, of course. That's our tradition here. We'd like to honor everyone when they first fell in love with point-of-care ultrasound. And why don't you tell us about that? And I forgot to mention, I'm Dr. Benjamin Galen, but my friends here on the chat call me Jamie. Thank you.
Thanks, Jamie. So my name is Dan Restrepo. I am the Associate Residency Program Director for Point of Care Ultrasound at Massachusetts General Hospital in Boston. And I actually can thank another member of this call sort of for being kind of my window and my entrance point into POCUS. So Dr. Tommy Heyne was actually the person that trained me a while ago. And I've always been a big proponent of bedside diagnosis and teaching clinical reasoning. And it really just became a way to kind of maximize our ability as diagnosticians at the bedside in a way that was patient-centered. And so it kind of just opened up this whole other world to me that allowed to kind of broaden my skills as a diagnostician at the bedside there with my patients. And so I don't know that I have a specific POCUS first kiss, but it was more of just like this really amazing realization.
Outstanding. And Tommy, tell us about yourself and if you have a case that where you first fell in love with point-of-care ultrasound.
Thanks, Jamie. I'm Tommy Heyne. I am the Associate Director of Faculty Ultrasound and the POCUS lead for the Hospital Medicine Unit. So basically overseeing faculty education within the Department of Medicine at MGH with Dan. And, it was in the ED where I think many of us in internal medicine, or actually I was med peds, first encountered POCUS, but it was a patient who I believe needed an MRI, but there was concern that he had a BB or bullet fragment in his chest wall, and the X-ray, was sort of hard to see. So basically, with slapping on a probe as myself as a junior resident, thought, oh wow, I know I can see that. So it's definitely outside of the rib cage, and therefore it's probably be safe. So a tiny little thing, but I kind of opened my eyes to this modality. I'd say global health is kind of my jam, and kind of why I got into POCUS in a bigger way. So just the real utility of POCUS and the global scene and sort of low resource settings.
Outstanding. And Chrissy, calling in from Oregon.
Hi, I'm Christy Schutzer. Thanks for having me today. I am a sonographer. I've been a sonographer for 22 years, and Dr. Renee Dversdal hired me at Oregon Health Sciences to be an ultrasound instructor for the medical school and the hospital back in 2015. I went back after that, decided to get my Master's of Education for Health Professionals, which I am days away from completing. And I think I've obviously loved ultrasound for a long time. I do a lot of women's health. In my prior life, I did a lot of women's health and MFM care, but love POCUS. And I think I first fell in love with the point of care when working with the PA students and the medical students, and their enthusiasm for this is infectious. They're so excited to be there. They're so grateful for the opportunity. And it really gives you a passion for giving them quality curriculum and education.
Outstanding. Congrats on the master's.
Thank you.
Great to have you here today. And Dr. Renee Dversdal, tell us about yourself.
Hey there. Awesome to see you all as usual. So I'm Renee Dversdal. I am a hospitalist and proceduralist out here at Oregon Health and Science University, Portland, Oregon, direct POCUS across the university. And in that role, I have passions and loves in getting it from UME, GME, CME, PA students, Doctor of Nursing Practice students. Basically, I think everyone that leaves our institution should be a pluripotent POCUS stem cell to go, whether it's via a residency or more of an apprenticeship model for our APPs, to go on and learn more about what they're going to do and serve their patients and their communities and their peers better with ultrasound. It's my elevator pitch. And so a little bit of the tie-in here is actually that I did my residency back at Massachusetts General Hospital in internal medicine. And so we had started connecting. I knew Tommy as soon as he was coming through his fellowship, Dan as he was getting trained up. And we just thought, let's do a little train the trainer type stuff, and then also work this in for the faculty to get that bolus. Because we all know educationally, now Chrissy Moore with her master's, but longitudinal training is more important to prevent skill decay, to develop competency. We know all of that stuff. But at the same time, you've got to have the bolus to get them over the inertia and that kind of fear of the probe. Like seeing the fear of the probe in somebody's eyes when they're an expert clinician, it's real. And so wanted to partner. Dr. JVS, the residency program director, was awesome and supported this training to get us in there to try to get them over the hurdle so that the awesome local team could then carry the torch. So it was an awesome project.
Outstanding. And did we hear?
Oh, I forgot my POCUS first kiss. Sorry, Jamie.
That you've popularized.
Well, and thanks hat tip to Gordy Johnson. So my POCUS first kiss, I started to really enjoy ultrasound at the end of residency, having been inspired by the awesome MGH crew, including Dr. Vicky Noble, who's now out in Cleveland, Andrew Lateplo, all the goods that we've all learned from. But I was back my first year on faculty working nights at OHSU. Had a patient transferred from a rural community hospital, hates doctors, hasn't seen a doctor in 20 years. He has a quote unquote pneumonia, hypotension, tachycardic. Throw a probe on, and I have no idea what I'm going to see. And he just has frank D sign, suggestive of something going on acutely, like RV, pressure versus volume overload. I do not want to get into the weeds with you all about this. Anyway, I ran down to the ER and I was like, yo, you guys, they call this a pneumonia, but this doesn't look like sepsis to me. And they said, get that guy to the scanner. And overnight, 3 a.m., we figured out it was lung cancer with bilateral PEs. And that was, getting to pass that off in the morning and feeling like a rock star. I was like, this is the best thing ever.
Amazing. Well, that case actually, illustrates, I think, sort of how, quick binary questions like that would be so helpful in acute settings, but why an old dog, master clinician might be interested in sort of learning these skills and incorporating them. It's a tough diagnosis to make or differential to broaden without, additional tools at the bedside. So, that case, I think is a really good illustration. But I'm curious, this curriculum, which you guys can take a close look at, on starting on page 9 of the April issue, POCUSjournal.com, indexed on PubMed recently, I should also add. I'm curious how this kind of came together. All of you have so much teaching experience. You have so many other curriculum that you work with, students that you work with, learners that you work with. I mean, we've got UME, GME, early faculty. How did the sort of older faculty come around to being interested, and how did this coalesce into the project and curriculum that you guys wrote up?
So I can sort of comment a little bit from the sort of the core faculty of the residency side of things, and I will pitch it over to Tommy to tell us a little bit about kind of like how this came to life. I think that there was a clear sense and over time with the residents that there was a present desire to learn point of care ultrasound, and that was a need. And fortunately, over time, our residency program, our program leadership started to kind of take note of that and sort of helped us by beginning to purchase probes. But then we realized that the folks that had spent the most face time and taught the most residents had largely no idea how to perform or interpret diagnostic point of care ultrasound. So really at that time, it became the sense that if we were going to do this, we were going to have to follow this train the trainer approach that had been mentioned. And fortunately, Tommy had already been training some members of the hospital medicine unit and our procedural team at the time, myself included. And it sort of just became the natural progression here of expanding this diagnostic point of care ultrasound curriculum to our core teaching faculty, who at the time was a 16-member group of folks that are largely 5 years or more beyond residency. Many of them were in their 20 years after a post-residency. So these are clinicians of a heterogeneous level of experience, but all very seasoned general internal medicine docs. And so it seemed the right thing to do was to bring in somebody who had already started creating a training pathway for faculty, but also with a national expert like Renee helping us out and getting to bring her back for a homecoming trip. It seemed like the right thing to do.
Maybe just to add to that, this is Tommy. Yeah, I mean, everyone, when we, I think everyone on this call has taught at national POCUS conferences and field lots of questions for people. How do I kind of get a program off the ground? I'm super enthusiastic about POCUS, but maybe some of the higher ups or the C-suite or so forth are not. Like, what do I do? And those are obviously, the real challenges. And finances are difficult and so forth. I think what was helpful, and then I think particularly at many of the more sort of Ivy League, we think we know the best way and sort of set in our ways type of thing. It can actually be even more challenging, or a very large academic institution such as ours. How do you kind of move a Titanic that's been moving in one direction? So again, as Dan sort of said, I think what was very helpful here was having Renee, who both has, and had been sort of offering a national level POCUS courses all around, with I believe some Australian colleagues, to kind of sort of add a level of legitimacy and expertise, so that what we were already doing kind of on a sort of smaller hospitalist divisional level would be sort of acceptable for the larger sort of department, especially again these more seasoned veterans. And I think it's worth mentioning Gigi Liu was also part of the training faculty. So I think known and loved by many in the POCUS world. So it was a real all-star crew.
Indeed.
And but it's just, I think, very helpful to kind of know your audience and know the folks and kind of what they're looking for. And in this case, I think really having an all-star cast was helpful to kind of get the pitch accepted to the powers that be.
Awesome. Let me ask a pointed question about the curriculum. So, there is talk of cognitive only pathways where, someone is sort of assumes that learning the image acquisition skills, might be psychomotor skills and technical challenges that, are either, challenging to so challenging that it discourages participation in POCUS from just the image interpretation side, or being a part of the dialogue, or integrating those findings into other clinical reasoning. Did you talk about sort of that? I don't want to call it a shortcut, just an alternative type of curriculum. I mean, how did you, conceive of going, the full length here with competency and image acquisition as part of the curriculum?
If y'all are okay, Tommy, I'll take the first crack at it, and then I'll kick it back to you. The super exciting thing for me was being able to go back to Boston anyway. We were going to run this Train the Ultrasound Trainer course regardless, and we ended up doing a smaller version in-house for Mass General and Brigham folks. It just ended up we weren't getting like the registrations, and so we were going to be there anyway. And we just thought, like, let's just go for it. It's just going to be so much fun. And the faculty, the clinician educator faculty, were so excited. I've never seen like such enthusiastic, engaged learners. I mean, like the people that I looked up to in residency, one of them saying like, "This is the most fun I've had in years. I can't believe I'm learning this new stuff. I'm learning more new stuff here than than in 20 years. And they were so excited. And so I absolutely believe that depending on your level of, are they contemplative, are they trying to prepare to adopt, you absolutely can do your sort of cognitive POCUS aspect. And James Anstey he did the study at UCSF with Trevor Jensen-Prosch et al. But now he's up at OHSU. So our POCUS group grows even more fantastic. I'm very proud of everybody we've been able to recruit. But the concept, you can totally do it this is for people that say, I'm never going to learn those hands-on skills. Why would I need to do that? But this group, they are lifelong learners and they were hungry for the information. So it was a true pleasure to get to actually do this hands-on training. And then, of course, Tommy, I'll let you chat about the impetus for your longitudinal work.
Well, Jamie, to me, you're kind of asking two questions. One is, the pros and cons maybe of, for example, for the initial bolus, how much of, for example, lectures. So our lectures were all in person, basically delivered, and then you'd kind of go to the standardized patients or the models and sort of scan on them and back and forth. Pros and cons of that versus as many, some of these conferences will do. Here's the lectures online. Go look at them, do these modules, and then we'll kind of do a quick recap and spend a lot of time at the bedside. This was pre-COVID that we first did this. I think since then we mostly do go look at the lectures. I'd say a very important logistical piece is that they were able to basically buy all these core educators' time. So they basically all got off this time. Was it 2 days together to sort of, okay, well, let's just do it all together, because I don't know that you'll all be able to do the lectures and look at them ahead of time, but you'll all sit together. And they had a lot of fun because it's a strong, tightly knit group. I think the second question is, well, for those, what % of those people who are learning this need to learn the hands-on versus is there a point, or would it be helpful to have some people who simply can interpret, simply look at the interpretation? And I think, it's I think we'll go into this a little bit later, but Dan and I basically will help run these every 2 months or so image review sessions, and there's folks who are in that who have not sort of continue to become super users and to really learn how to use it at the bedside to acquire the images, but who are pretty good at interpretation. And so certainly I think you can make a great argument that maybe other people are teaching the residents or themselves performing these images, but just that they know what B lines look like and what they mean, and that's a B line and not an A line. I think that's a lower hanging fruit with, I think, a lot of merit.
Very interesting. Thank you. Christy, I'm curious, you're such an experienced sonographer yourself, and, what was it like working with, these sort of adult learners? Even the UME and GME learners are adult learners, but different types of docs who are learning how to acquire images. Was there any sort of any observations, anything unique that you noticed, or any other advice you'd have for old dogs learning new tricks?
I think that as I've gone, and I do a lot of physician training as well, GME, CME, and they're in a unique position. And I think there's a way to teach them. They're in a position where they're not only learning the skill, but they're learning how to be instructors. And so that's a really unique and a hard task to fill, because they're going to have to teach it and support it, as well as just learn the skill. So we do a lot. I actually really feel passionate about developing fundamental skills, and through task deconstruction. And we talk about the 5 basic motions of ultrasound, and we really just present that, like, here's how you fan, here's how you rock, here's how you do this. But really, when you're an instructor, you need to be able to not so much even perform the skill as to be able to guide your student while you're not performing the skill, just with your words. And so really breaking down each of those tasks. And I've found that this is so well received when you not only say, this is how you rock the probe, but let's look at what that does to your image. When you rock the probe, you're also centering, you're also moving things from left to right, you're changing your angle of inclination, so that when they're watching, now they can know, oh, that student, that kidney's moving from left to right and kind of moving off the screen. I know that they're rocking the probe when they shouldn't. So you're really, by breaking it down in that way, you're giving them the skills to perform it, and you're giving them the skills to teach it at the same time. And so that's something that I feel like we don't do enough of in POCUS education. And I really feel like it's impactful, and if it's easier for students to learn, and it's easier for instructors to instruct when we break it down in that way. So that I really loved that about this group, and just kind of talking to them that they have this double challenge of not just being learners, but also being instructors.
That's really insightful. Thank you so much for sharing your reflections. Dan, I think you were saying before we got on the recording, some observations you had about this training program that really involves uniquely graduates 20 years out from residency. What are some things you found that struck you that you'd like to share?
So yeah, I'll tell you kind of what struck me the most. So I'm also a member of the core educator faculty, but I was relatively junior in my POCUS journey, so I got to just kind of sit here and absorb all of not only the master teachers doing what they're great at, but also kind of absorbing how this very unique group of learners process this brand new skill. And so I guess one thing that I really did notice a lot was that nobody settled for a weak answer. Nobody settled for cutting of corners. Everyone wanted to know the why, and they wanted to know the why to the point where it was draining our time. And it wasn't possible to be like, well, yeah, sometimes you have mirror image artifacts. It would be like, no, you need to tell me, because that's going to confuse me and I'm not going to be able to get through here. So I think many times when you're teaching a more junior learner, they'll be like, okay, that sounds pretty good. Maybe I'll look that up later. But these people were because I think like any good teacher, knowing the why will always let you be able to teach the concept better. And I think that they have incorporated the why as their key to learning. And so the degree with which I think folks wanted granular explanations for things that I think I had previously glossed over as an educator, I thought was one big takeaway. The other thing, which was more of a practical point, I noticed was, and I think that when you think about it, this just makes sense with learning theory in general, is that if you can draw a parallel to a concept that's already well engendered in your brain, you'd have you'd have quick kind of adoption and understanding of the concept, but also you'd engender this excitement that was unbelievable. And I think back to one of our faculty members who's like the jugular venous pressure master. The guy has literally, has a model of it and teaches it and he lives it, but he'd never really seen the top of the column of blood, right? We all infer it from the flicker, but when we showed it to him, oh my God. And then when we showed the IVC and the jugular vein tip, it was, and he got it, right? He got those so quickly. And I have to say that drawing parallels to what folks already know and teach is free money. And it's also just really cool to watch because people light up when they're approaching something that they already knew from a different angle.
I love it. That's I can see that magic in that adult learning classroom. The anecdotes are really helpful. For me, if I was teaching something and someone kept asking why, eventually I'd have to call Renee and ask her to tell me why, because I'd reached the limit of my understanding. Or I'd have to text our WhatsApp thread of national experts on the topic about details about an artifact or some of the ultrasound physics. But do any of you remember a time where this sort of drill down on the why reached your own limit and how you sort of handled that in the moment as trainers training the trainer?
It's an excellent question. I don't know if I can, you're very charitable, by the way. I don't know if I can think of a specific example. I don't know. Sometimes I just go back to general clinical medicine. And so sometimes I don't know the answer and I don't know how to tell my patients the answer. I just say, but we ruled out all the bad stuff. And so I think sometimes saying, I just genuinely can't tell you that, but I'm going to contrast it with X, Y, and Z. And this is how my brain processes it, even though I don't understand the why. And I think just being humble in general, I tend to be, one of my chief residents at Mass General after my senior talks, you're way too colloquial. And I'm like, oh, I love all my chief residents. They're all amazing. But that just happens to be my personality anyway, going from Oregon back to the East Coast. But especially in this setting where it's, you have to make it psychologically safe for them to be vulnerable and to not know. And so them asking those questions, I think, is almost their way of trying to almost get back in control of it. If I can understand this, it'll be better that I'm still struggling at this other part. And some people visuospatially get it faster. Some people, image interpretation get it faster. And so the biggest thing is just try to, be vulnerable yourself. I love my Brene Brown. and try to make it psychologically safe for them to be okay not being good at something and not knowing all the answers, and just normalizing that.
Excellent. It sounds like a sort of shared vulnerability, really, that like the learner, the training folks that you're teaching, they're really vulnerable here, touching a probe for the first time. They're going to have a lot of sort of technical struggles, and someone they trained a while ago has to kind of watch them struggle. It's like watching someone try to parallel park or something. It's embarrassing. So, but your own vulnerability around what you do know, and I'm just curious if there are any sort of resources, maybe other than POCUSjournal.com, that you'd go to for for answers when when they kept drilling down. I mean, there's a lot of stuff we take for granted as sort of routine POCUS educators about the physics, or about some of how we integrate the findings, that we haven't looked at the primary literature of every single sort of textbook level POCUS finding or technique, or so does anyone else have any recollections of being pushed to their limit by some of these old dogs? Tommy.
Yeah, it's Tommy here. I mean, I'm trying to remember exactly, but I think there were a couple of times it's like, well, what's that? What's that in that little part of the screen? That's not what I'm trying to talk about. And I mean, to some, so I think the helpful general concept to try to continue to repeat is, we're staying in our lane. We're staying in our lane. Other than Chrissy, we're not like officially trained sonographers. We're not radiologists. This is POCUS. So we've got like 2 dichotomous questions we're answering here. And beyond that, you can get a more comprehensive exam if you like. And that's so it was a little, between, that's an interesting question, we'll need to look that up or look it up. And also kind of like, it maybe doesn't matter, like to try to sort of say that if you got good at reading this one part of some other diagnostic imaging, whether it's an EEG or a MRI or something, well, in the end of the day, radiology and neurology are the ones who really need to read MRIs really well. And there's some things on MRI that I'm not really sure what that is, and that's okay. And I can just say I'm not really sure what's in that bottom left part of the screen there. But what I can tell you is that within what we're trying to do here, we're looking at this part, and I can answer these 2 or 3 questions. And beyond that, if we think it's clinically relevant, then we need to, get other imaging or so forth. So I think try to repeat that mantra. But yeah, it didn't always go, that wasn't necessarily to fulfill the thirst always.
Yeah. So it sounds like turning it around, to highlight and emphasize, the limitations, and define what POCUS is against other, consultative exams. I think that's a really, really nice strategy. Christy, you were going to say something.
I was going to just add that I developed as an educator at this course, because the vulnerability was not just one way. I mean, we were at Mass General, I know Renee is, she did her residency program there, but for me, these are, highly regarded physicians. And this was not a gimme. We started with you could feel sort of the reservation and the skepticism in the room. And the question started, but I think as an educator, meeting them where they were at, answering the questions, and ending with enthusiasm was so to start with kind of reservation and skepticism and end the program with enthusiasm and energy was great. And I think as an educator, really having to stretch it, this was not like doing medical students. Medical students are like, what do I need to know? Give me the basic information and let's get out of here. And this was definitely not that. But it was really, I think, a learning experience for, I would say for Renee and I as well, just being able to reach this group and have such a satisfying outcome at the end was really fun to be a part of.
Awesome. I have another question about sort of how you encourage them longitudinally. I know, Tommy, you'd mentioned about this is really an ongoing, curriculum for these adult learners. They're doing teaching, but they're also on their own journey. What are some strategies you use to keep them interested over time and keep them involved? And, it's an issue for all learners with POCUS, that there's some attrition after initial, bolus course like this. So what are some take-home points and recommendations you have for other listeners?
Yeah, I mean, honestly, I think that's at least for in my experience, the hardest thing. So how do you capitalize on that initial enthusiasm to continue? So it's one thing to get pretty good at scanning a couple models over 2 days, but our goal, and there's obviously different models of how you do this, but we've adopted the ASAP emergency physician model, in which you need 25 scans per application. So kind of go through on real patients, real pathology, and do an OSCE at the end. So, however it's done, but the idea that you really need just do the reps, get the reps in, first with sort of hands-on help. And then as you're doing it, either maybe with a peer who's learning with you or sort of on your own, and then getting, if not real time, shortly thereafter feedback. And that requires time. And, these are all busy clinicians with when they're in the hospital, typically trying to get their work done and then go to their families or so forth. So I found that I don't know what the holy grail is there. A couple of things I've sort of learned along the way, or maybe sort of learned along, obviously if you have the administrative and financial support for any sort of carrots and sticks. So carrots might be, well, at the end of this, you get, what is it? You maybe get one of these less expensive handheld probes, or some other incentive. Perhaps you've basically had some of your time bought off. So actually, instead of sort of a clinical session, you're supposed to do like you are, because I think that's the folks who have now trained a number of people sort of since this event that we're talking about, both at MGH and other sort of area hospitals, and it's the people who are able to just put it on their schedule, put it on their calendar, say I'm gonna scan with Tommy or whoever the educator is, and those are the people who kind of can push themselves across the finish line. Whereas with others, it doesn't all necessarily work. So how to kind of do that? Maybe again, sort of buying off someone's clinical time, I think would be ideal. Sticks. Yeah,
I'm really interested in the sticks. I was enjoying the carrots, but I couldn't wait for the sticks. I want to know.
Yeah. Well, so a couple of things. I mean, I think one is, obviously if you've got sort of whoever's the director of whatever group you're saying, kind of putting a little fire to their feet and saying, hey, the sort of expectations you're going to do this. And with the idea being, if this is a privilege, maybe X number of people applied, X divided by 3 is the people that were sort of accepted. And if you don't complete it in this period of time, well, then maybe we're going to let somebody else do it in front of you. And so maybe that kind of, gets a little bit of interest, or, for example, we've talked about for procedural, so the hospitalist proceduralists, a sort of similar idea. If you don't finish your training X period of time, well, maybe you can't be part of the proceduralist group anyways, because this is sort of the expectation. So
that's a necessary extrinsic, motivator is that they have to, meet the requirement. That's sort of getting a competency to be able to perform the study or the procedure that kind of pressure. Do you find that works for this, learning population?
I mean, I think an email from a director saying, thanks for your hard work on this, continue. And I have a leaderboard, for example, that I publish, and they kind of know about this ahead of time, but sort of where are you on the leaderboard and who's kind of the caboose and who's the head of the train, and, peer pressure. I would say is maybe the last thing I found to be helpful is, sort of peer pressure, but also peer support. So I think the people that have really done well, we mentioned that this is sort of a tightly knit group, but maybe it's that, so the clinician that Dan mentioned earlier, who was just so jazzed about JVD and has a model of like what the JVD looks like in a mannequin in his office, he finished his training and he does so much JVD now. And like that, he does clinically what he's doing. But I think what helped him, he's like many kind of after a couple months, so hadn't done so much, but that I think he just looked at his schedule and realized, well, there's like 3 weeks when I'm on around the same time that, I don't know, it was maybe Dan was on or one or two other people who were trained, or I'm on. So the idea of being like, well, I'm going to be in the hospital anyways. I don't want to just try to put an hour of my day when Dan and I can go or he can kind of watch me scan some patients, or again, similarly with me, I kind of have them, sort of bolus part 2 is that they need to schedule a certain number of scan sessions with me. But however it is, that the idea being, maybe it's a little less intimidating, or maybe a little bit more sort of this positive peer support that we're kind of scanning together, and it's all latch on, if not someone who's fully trained or someone who's kind of still learning the ropes with me. I found that that's pretty helpful, and that's, I think, helps a lot of people kind of push over the finish line. I'd say maybe the last thing that comes to mind, as somebody who Dan can speak to this, but maybe Dan, you can talk about an AI experience that somebody had recently at a conference.
The AI experience?
Well, didn't you say there was something with one of the probes with artificial intelligence?
Exactly. Yeah. So the only other thing I will add before jumping in on that is to the extent that I found the leaderboard as a person who completed the same training program. Actually, I use it with the residents, and I actually found it. It's a great way to generate sort of like, hey, you and I aren't doing that hot. Maybe we should just like knock out a couple scans, and then we can kind of do those together and kind of help each other. So I do think that the leaderboard itself was not. It was like the carrot stem, I guess. It's sort of a hybrid between the root of the carrot and a stick. So I don't think of it as a very like negative kind of extrinsic pressure motivator. But for example,
let me ask you about the leaderboard more. Sorry to interrupt, but I think our listeners want to know, like, this is number of scans, or like it's an approved scans or the best scans, or how does the rank list follow there? It's just number of scans, like.
Well, it's never. So I mean, right. So again, if their scans weren't saved to the cloud properly, they're not going to get credit for it. If their interpretation was so terribly off, they're not going to get credit for it. But we're all human here. So basically, if you did the scans and you saved them correctly and your interpretation was totally off, then you'd get the credit for it. But then it's basically listed. So we do 6 applications: heart, lung, IBC, renal, bladder, FAST exam, and sort of JVD/soft tissue. So for each of those, it lists how many you've done and kind of had approved. So you only got roughly 15 for each of them or whatever. Well, you're a little over halfway versus here's somebody who's only done 3 heart and 2 IBC and whatever. Well, they kind of need to get their act together.
I love this. I actually have never heard of this articulated, the leaderboard, concept. It's unless I missed it when I was proofreading your article as the editor-in-chief. I read it very closely. I don't remember that being published as part of this curriculum, but I really appreciate your sharing that for our listeners, who are, a lot of them are educators themselves, trying to whether it's training residents or a group of faculty. That's such a nice idea, and to learn that it worked. Dan,
they just add one thing just to that that's helpful is using a red cap in like an Excel little algorithm. And I'm not at all like a computing nerd, but basically the idea is every time they finish their scan, they put it on a red cap using their phone, and then I can download that data, spit it through Excel, and then that sort of auto-populates those numbers. So I'm not spending all day like counting them manually. So there's ways to do it that are smart.
That's a great tip. That's also for the learner. It's like a little satisfaction, crossing it off the list. They feel like they've sort of met the metric, and they know they're going to be maybe a little higher on the leaderboard. So that's awesome. I love it. Dan, you were going to say something else about the I think the leaderboard, or the just
I think in general, sort of like any way to keep things exciting, but also any way with where we can kind of harness the power of new technology in the ultrasound space to really help us minimize the amount of effort that we as educators have to be at the elbow with learners. And I think what Tommy is referring to is really my boss and the head of the core educator group was like sauntering around at a national conference, and there was one of these new sort of ultrasound AI platforms that will actually label structures for you and give you sort of guidance in terms of image optimization. And he was like, he came and found me at the conference, and he like shook me and handed me, had made me go see them because I think it is a little intimidating for a learner on their own that, maybe fell off the train and hasn't scanned in a month and says, well, is the apical 4 with the indicator to the, where was that? And like, I just see like a pumpy blob, and I don't actually see 4 chambers. How should I, and so to have, if we can harness some form of technology to help us and be like, no, that's actually the right atrium, not the left atrium. That was, I think, another idea of like, how can we keep things fresh? Because it's cool to see those things on the screen, but more importantly, how can we lower the activation energy to scan and like kind of remove that fear of bouncing around the wards by yourself without anybody to kind of help you, and not want to waste Tommy's time and send him a picture of like a shoulder when you were trying to get to the bladder. So I think that was sort of, I think that there's a lot that remains to be seen with AI and ultrasound, but like that certainly seems like, from like a pedagogical standpoint, a really desirable way that things are going.
Amazing. I mean, it sounds like as faculty who are teaching a lot of residents, it'd be hard for them to, if they don't have the confidence that you all have, as national experts, that it would be hard for them to have a group of residents and med students, in a room, and for them not to know the structures, and for them to have you as a resource as their mentoring faculty, but also to have other technology to help them stay on track and help them feel confident in what they do know. That's really awesome. That's the future. It seems, some AI applications. Speaking of the future, I think this is a living curriculum. We're so lucky that it's published here. I think you're still teaching it. You're still doing the curriculum. Some of the tips you provide here on page 11 of the April 23 volume 8 issue 1 of the POCUS Journal, available for free online, free to publish and free to read. But page 11, table 1, you really enumerate a lot of really great tips on what you've learned from teaching senior faculty learners. I think the listeners can take a look at that page to get into some of the details about some of the tips. But I am curious, as we're coming to the end of our podcast here, what your sort of future directions are, all of you, in terms of training adult learners or other curriculum that you're working on, and maybe along those same lines, if there's anything, looking back at this experience from the last 4 years, that you might have done differently, having gone through it. So two questions there. Maybe we'll see, Renee, if you want to start out.
So I'm going to make you repeat the question again.
So yeah, I think
two questions. I'm sorry. I'm just gonna.
I was, thinking both, what are future directions here, for adult learners or training senior faculty. This is a curriculum that's ongoing, but sort of future directions, and then sort of alongside that, looking back on this, if there's something you might have done differently. Overall advice for anyone else looking to do, a curriculum similar at their institution.
So sort of like a sort not really a pun, but I was trying to push you a little bit. So something I've learned in my non-academic job is figuring out the pain points and asking questions of people. What do you need? What are your barriers? What can I do for you? Instead of me telling you what you need to do. So sort of having you repeat it for me was trying to make a play on that. I failed. I'm sorry. But I think the biggest thing I learned is I need to ask more questions and do less telling. And so I think that we did a great job breaking it down into the basics and everything. And then a little bit more follow up. I love, obviously, the longitudinal part, but the future directions would be, what are you hearing the most about on the wards? What are your biggest concerns? What are those use cases that you are just terrified when a resident comes to you with, and targeting to that more than kind of just the classic curriculum. And I guess that's kind of also the lessons learned. I'm really trying to, I'm a talker, man, I will fill space, but I'm trying to do more listening and then tailoring my approach to people.
Awesome. Thank you so much for sharing. Christy, anything that, I know it's a very big 2-part question, just generally advice for other programs, but looking back, anything that you might have done differently, and then some sort of future directions, learning from this experience, what you might do going forward if you're doing a new curriculum or additional curriculum.
One thing, when we're talking about learning acquisition skills and then that continuing education, I feel like Tommy and Daniel hit on a very key point, and it's of learning alone. And AI can help, but a lot of times we don't have access to AI, especially right now. Partnering is huge. And I don't think I necessarily recognized how the partnering worked all the way from medical student to physician. So I have an outside opportunity where I mentor physicians, and we do one-on-one training. And I have had multiple of them demonstrate that desire that they would rather partner with other people at their institution. And now we do more of a group format. And so I think the thought is one-on-one, it's the best, but really as a learner, I feel like having that partner that's at the same level as you are, whether it's sending the medical students out into the hospital to scan, giving them tasks. So we've started doing that in a way of where we don't have a lot of resources and scanning one-on-one with the medical students, but maybe they meet up with faculty. We have a patient or two ready for them, and we pose them a clinical question, and then we want them to go scan. Then they come back and they partner and they discuss and come up with a plan. And so I feel like those, I don't know, it's a change that we're just now implementing, and I feel like it's working so well on various levels that that's, I think, going to be a drive for our future.
Outstanding. That's really, really interesting. Thank you. And Tommy, did you sort of, I guess, in closing, have any reflections or future directions?
Yeah, again, I agree with sort of Renee that these things are tied. I think there's the micro level stuff, which is, how much time do we find that we waste just trying to find a patient, or oops, they're in the restroom or getting a shower or something. So, stuff that I've kind of learned along the way to, have a nice list of patients ahead of time, talk to nurses, talk to clinicians for, sort of people that can be scanned in the hospital, or who's on their list. Or even, honestly, and I want to give credit to Renee and Chrissy, because the idea of using the 5 motions of the probe and sliding and rotating, that, as opposed to, let me just grab the probe and kind of get it. Like, honestly, I learned that more than anybody from them, more than a year of fellowship. So that, that idea of sort of sitting on the bedside and rather just let me grab the probe and kind of wiggle around, but let's think together, what movement do you think you would make to improve that view? So on the micro level, that on the macro level, maybe just reiterating that, a little bit like Renee was talking about, almost sort of like a needs assessment and what is it that folks need. But I think just being trying to be realistic and trying to shoot for the moon, sometimes you won't get that. So just a simple thing, but is who you're training. Do you really need 6 different? Do they really need cardiac? Cardiac is the hardest, and you can argue on the day-to-day, for example, as a hospitalist, how often do I need to get an apical 4-chamber view? So I think some of those questions ahead of time and thinking hard about what is the ask you're asking of people. Are they supported enough that they'll be able to kind of come through with it, have the timing for it, have the scheduling time, or are they as excited as they are they frankly just sort of too busy for it? For example, the acquisition, maybe they can just learn the interpretation.
And I would actually piggyback on that last point. And as I think about kind of like how we scale this up to faculty, some of the faculty have there was some initial excitement, or they thought it was pretty cool, but it was more of a novelty, and they do show some degree of apprehension. And so do we have to really lean in and make sure that everybody can get an apical 4-chamber view, or can prove whether or not there's hydronephrosis? Like, I don't know the answer to that question, but like, I do think it's pretty interesting to think about that idea of James and Trevor's paper on cognitive POCUS that you had mentioned earlier in the talk. Like, can we just maybe I won't be the attending that can get the images, but I can interpret sort of everything that you're throwing at me. And maybe I can't coach you into how to get a better one, but maybe somebody is kind of bring me, I can sure tell you whether or not there's a pleural effusion there. And so just bring me the images and I can tell you that. And I can overread your scan. I may just not be the person that coaches you to get a better picture next time, but I can help you. I can double check your interpretation, and probably better than most, I can help you with the integration of that and how we take care of the patient and how that affects our reasoning. So I think that maybe that's something to consider in the future in terms of where we take it.
Well, these insights are really, really helpful, and we're so lucky, the POCUS Journal and the POCUS community, to have your contribution and collaboration, in our April issue, and available for everyone to, learn from. I do recommend everyone take a look. It's POCUSjournal.com. The page 9 is where this curriculum starts, and especially table 1. We didn't have time to cover some of those tips and tricks. Really worthwhile for anyone teaching adult learners, whether they're med student adult learners or 20 years out from residency learners. Those are tips and tricks that can be applied. Lots of great stuff in the curriculum that was published. And we really are so fortunate that we got everyone here together. And thank you again to our co-authors for taking the time to join the podcast as well. It's great to see you all.